So today, for this workshop, we're going to be discussing everything HVA, okay, from a coalition and organizational perspective. So, what I'd like you guys to kind of wrap your mind around is that um, we did one of these a couple years ago, a fairly in-depth one, about 2 hours. But when we look at HVAs from a regional vantage point, and the worthiness of what that HVA does for the region in the health systems in where they provide. We'd like to make sure that we have functional information. Everyone seems to be acutely aware that there are HVA requirements, whether they're federal CMS requirements or otherwise, just general good business practices for organizations. But how we leverage that information over time, update it over time, and use it to kind of guide us in our IPPW, our integrated planning, preparedness and planning workshops or whatever, developing, what our training and exercise battle rhythm is going to be. We have the need to do this. Now, one of the things that we run into constantly, and right now we got a decent mix of healthcare organizations on here, some hospitals, or excuse me, I say healthcare organizations, local health departments, and hospitals on here now. But that's not all of the coalition. The four primary coalition part, or not, I won't say coalition partners, the required coalition membership requires a group of hospitals, EMS providers, local emergency management agencies, and health departments. Across each one of those disciplines or organization types, there normally is a requirement somewhere to conduct an HVA. Each one of those may look slightly different when we go through this process. In the past, we have, as a coalition, been directed to use the SIMP product. That is, I'm going to go ahead and share my screen right now so folks can, for those who are not familiar with SIMP, they can kind of see what this is. And I'm inside of the which is Illinois EMS Region 4. That's our coalition version of SIMP. And inside of that, they have some tools that enable us to be able to put together some form of assessments. You'll see stuff about the capability planning guides, and you'll see right here where it says vulnerability assessments. And what has happened in the past is that organizations, hospitals specifically, have access to SIMP, and their information goes into SIMP, and then it rolls up together as a collective evaluation. So here, this would be, our natural hazards, technological hazards, human caused hazards, hospital facility based hazards, and it ranks them as you guys are traditionally used to seeing when folks are putting in, what the human impact, how prepared you are, etc. This is the roll up that I get when year by year hospitals will fill in their HVAs. Now, again, I said this is specifically hospitals. So what does that do? That puts us in a position where we don't see, even out of the four, again, our four primary um, organization types: EMS, health departments, EMA, and hospitals. I only get one out of those four. So at best, I get 5% visibility on HVAs across the region. Now, it is entitled and has been called over years the Hospital Preparedness Program. So this is where the focus and money is gone. But when it comes to a true actionable health system HVA, we really don't have it. We don't have that. So we've tried to, in the past, bridge that gap by understanding that the SIMP is only accessible to hospitals, and we tried to move over and make it so that folks, hospital and non-hospitals, could use another tool to complete the HVA. And once they complete their HVA, we would consolidate that information into a single document. So what we've done in the past is we've had this. We would have hospitals um, use the Kaiser Permanente tool, and this was part of the reason was SIMP was down for a while, but we knew that we had the gap that other organizations could not use it. So we offered this up as a potential tool to do so for EMS folks, local health departments, et cetera, and then consolidate it. Probably a tool, probably not the right tool for the job at hand. So it kind of puts us into a, again, dilemma where we have hospital specific tools that don't reach across the health system and different organization types to give us something that's actionable. Now, bottom line, I can just take the health or the stuff in SIMP, have folks do that, and I could probably consider myself or consider the Edwardsville region, the Hope Coalition, done and can fill the federal checkbox. So when we go back um, to ASPR, they'll look and say, okay, yeah, they did an HVA. Yeah, we can definitely do that, but it doesn't lead to the actionable piece that we really kind of need. So today, I would like to kind of discuss, kind of create an open dialogue on the tools that we have at our disposal today, how we can better use those tools to get information from the four, at a minimum, the four major players in the coalition, and then maybe what we could expand that to some of our secondary and tertiary partners across the region. And when I say that, I'm looking at long-term care facilities. I'm looking at dialysis centers, ambulatory surgery centers. Should we want to open that up and provide them an ability to um, input what they have as an organization, have that roll up and allow us to see it and help us make better decisions going forward. So I said a lot of words over the last 9 minutes, so I'm going to slow down here, stop talking as much. Just want to make sure that everybody understands where we're at with kind of the dilemma and what I'm attempting to achieve going forward. So I'll pause for a second, and I'm going to pick on some folks that are here. So I'm going to pick on Kara, just because she's the first name that I see, and she's right in the middle of my screen. Kara, is what I'm saying? Are you catching what I'm putting down? And what are your thoughts from your guys' perspective as as a health department and vulnerability assessments at the organization, or I'll say the jurisdictional level for what you guys do, St. Clair County?
Well, we do our HVAs in SEMP also.
Okay, so you guys put your HVA information in the public health side for your version of it, which doesn't necessarily cross over to ours.
Right.
Yeah, which doesn't feed ours currently. Okay, and what's that process like for you guys in using SIMP, and like how I can only speak to what I've seen in SIMP, and here I'll go back to it now. Is it the exact same
Yep.
groupings?
Yep.
Natural. Okay, so it is the same this way, but it does not. Okay, so we just don't receive that. So okay, I mean, I guess score one for that gives us 50% of the four. And as far as the process, are you guys doing this annually?
Yes. Yep.
And who are you incorporating when you guys conduct yours? Is it just folks within the local health department? Are you, when you're making your determination on all of the elements of each one when you're answering each question? And I guess I probably could go to these. Let's see if it'll open up. Yeah, because this is BP5s. So when you're going through each piece in SIMP, who's doing it? I mean, is it kind of like a Kara, you're it, you've got it, or do you guys have a larger group discussion? and or any surveys where you're pulling your information from to make your determination on how bad is bad and how prepared is prepared?
Well, a lot of it is carrier it, but then also we do use some surveys, just to see where we at, what has changed. Are we about the same? What have we done to improve it? So I think it depends on the year coming back after what we've just been through. Some things have changed and opened our eyes. Others have remained about the same, so it's not that difficult. So I think it would depend on each section. So I'm about to do it for this year as well.
Mhm. Okay, so I see Sam join. Sam, so since I'm talking St. Clair County now, what's the county's battle rhythm for updating? And I know we're not doing a straight HVA at the county level. Probably doing more of a thyra. What is the battle rhythm there? How often is that up to date? Is that updated? Sam, if you are talking, I know I've called you out of I plucked you out of an abyss of names. But if you are talking, you're muted.
Phil, I believe she's bouncing between two different meetings right now.
Oh, got it. Okay. No worries. No worries. Um, I see Kendra on. Kendra, can you give a kind of
I'm sorry, Phil, this is Sam. Were you asking me a question?
yep, I'm sorry. Lee said you're probably bouncing between two meetings.
Yeah.
And if I need to, I can go to Kendra, but I did want to get a kind of perspective from the EMA side.
Okay.
I know, most of the FEP stuff and HPP program stuff requires an annual HVA review, update, and SIMP.
Mhm.
What is the requirement from an EMA perspective now? Are you strictly within like a THIRA 3 to 5 year update of what we do for hazards, vulnerabilities, et
It's
cetera?
same thing. Essentially, it's an HVA, but it's in thyra format. And yes, we have to update it every couple years.
Okay,
If
so
that's
it's not an
something that you
annual one.
guys no. Mm-mm.
Okay.
So if that's something you guys would like to include, I don't know if you want to as an annex or anything, let me know. I'm happy to get it to you. Um, just as county involvement, we can certainly do that.
Yeah. And does Doug do anything do you know if Doug has ability
I don't know if
to,
are you talking regionally or just
yeah,
like,
for the EMA region?
you know, well, I guess my question is, are you looking to see like what surrounding counties, like
Not
compiling that
necessarily.
information?
No, not necessarily. Right now. I'm just kind of curious of the, um, of the again. I use battle rhythm, but the timing of when we go through this process. So again, hospitals, health departments are doing it annually, and I know thyros are normally, every few years,
Hmm.
depending on the jurisdiction. And then from a regional perspective, is Doug pooling, St. Clair, Madison, Monroe County? Is there something? Is there a like a filtered document or system that he's able to look at, and then that goes up to the state? I use SIMP as the example for the hospitals and healthcare, how those roll up. If you remember
Sure.
how those used to
Yes.
roll up, yeah. And then does Doug have any system that's similar from an
I
EMA
will,
side?
I am not completely sure of that off the top of my head, but I will be with Doug this afternoon. So I
Okay.
can ask him that information and see if, he has something that compiles all the surrounding counties, and let you know. But I don't know the answer off the top of my head.
Okay, no, it's no problem, no problem. So yeah, that would be something I'd like to kind of run down, so to speak,
Sure.
just so we can have a perspective. And then on the EMS side, I don't know if John was able to join. He did sign up. Let's see. Nope. Anybody from EMS on here that I may not see. Seeing our houses. Okay. Now, I will say this, most of them do not have a direct requirement for an HVA as an organization. Now, business-wise, definitely a business continuity plan, and an HVA will be great, but understandably, they do not have a standard that requires them to have an HVA. Okay, so there goes that battle rhythm. Okay, so as far as the tool sets that we use, so Patrick, I'll pick on you. I don't know if you got, I know you were moving around. Hopefully you got um, some microphone accessibility. Let me know if you don't, you can type it in. But what are you guys doing when you're when you're conducting your HVAs annually?
So
Or
this is
every other year potentially. I will say that because I know the CMS requirement is every 2 years, but the folks that are the coalition has an annual requirement which we kind of pull from the hospital. So I'm sorry, go ahead, Patrick.
No, that's okay. Like I said, this is actually my first time going through this. So um, I had talked with Tim Claxton, who was kind of advised me what we're going to do is set up a review of some key players here at the hospital, kind of go through the list, I guess, figure out and rate these where they're at. And then I was actually just trying to find out if this is something, is Kaiser Permanente the way to go for us for to log and keep track of these, or is it better to use SEMP, or which is more appropriate and would help us be more in line with the coalition. Um, and then I think the other thing that we had talked about is even moving that into the community and bringing in police and fire to kind of do a full community-based HVA, not just so it's not just our hospital.
Understood. Yeah, they will always be a great resource for you, obviously understanding what local fire and et cetera can provide. So when you're looking at your preparedness and yada yada rules, but again, it'll still be only for your organization, if that makes sense. Whereas once you move outwards to your health department and your local EMA, those would be a little broader and a little bit more accurate to the community's full preparedness. So if there's, I know you're saying this is going to be your first go at it. I would say that if you, when conducting your HVA, you try to limit it to your facility as much as possible, not the partners that help contribute to it. Again, I would applaud you and encourage you to have, your local fire, police, whomever you deemed fit to provide input, because they're going to be able to, even your local EMS agencies, when you start talking about impassable routes, et cetera, who better to tell you that when there's some flooding going on where you can't get to other than an EMS agency because they're out in it all day. So, no, that's good to hear. So in your question about what we're using and, is the Kaiser Permanente tool the way to go, et cetera. I mean, I feel that, to my core. I will, I'll say that I feel that to my core when you um, make that, like what's best, what is the best case. So what I will say is this, is that I'm gonna pull up another I'm gonna call it a slide, but this right now, you're looking at the scope of work for our grant, right? For our grant as it is right now. So this basically dictates as a coalition what we have to do. So in here, it says the Readiness Response Coordinator or employee, collaboration with the HCC must complete a hazard vulnerability assessment annually by January 31st and submit evidence in the CAT. So they have taken out the SIMP requirement. So uh, good, bad, or indifferent. It used to say, we'll conduct your HVA annually in SIMP. It no longer says that. It says submit your evidence in the CAT. Now, the CAT is the coalition tool. It is a tool that the states and the federal government at ASPR utilize to track deliverables outside of the scope of work. So keep that in the back of your mind when we're talking about what tool we can, what we should and shouldn't use. Okay, pros and cons. Let's talk about a few things. So I'm gonna pick on Georgia. Yep, Georgia's still on. You guys, I know in the past, if I were to go back to one of these folders, I could probably pull it up. But let's see, right here. You see that right there. Memorial Hospital, Chester, HVA. I was in the 2021 folder. This I probably could. Is that the one that I opened up already? Let's see. Yep, that's your guys's here. This is what you guys submitted to us in 2021 as your HVA. Now, what are your thoughts on the use of the Kaiser Permanente tool, Georgia?
I use that for my outside clinics when I thought it was a requirement. I thought it was fine either way, SIMP or that.
You said you just thought it was fine.
Yeah, I'm
That's
sorry.
okay.
I don't have any more to add to that really.
It's okay. It's more than okay. Who else we got on here? Hospital-wise that have used a. Don't shout out all at once. I'm trying to see. I can't. Some of those folks I can't tell. If you're working out of a hospital or not. Anyone else from a hospital perspective have any feelings towards the Kaiser Permanente tool? Here, I'll pick on someone. Lee, talk about the Kaiser Permanente tool. Pros, cons. What are your thoughts about it?
In part, it depends on which version of Kaiser Permanente you're looking at, because there's two different variations of it. There's the old one and then there's the current one. The current one is far better than the old one. However, for a regional HVA, it's a giant pain in the rear because we have to take each of the individual entities, completed HVAs, consolidate, do the math, and try to come up with something. Um, it's probably better than SIMP simply because care for SIMP's interface. However, again, your mileage may vary.
And what Lee is talking about as far as the we have to take that manually, which you're looking at now. Hopefully you guys can see that, or that must. Okay, can you guys see that? It should be the Edwardsville Regional HVA results. Can you guys see that?
Yeah,
Or
it's
not?
there. Yeah, it's
Okay.
there.
So what it is I take all that information, copy and paste, put it all in, and then get into a spreadsheet. And this is, I mean, you probably see this exact graph inside of our, inside the EOP. You'll see this exact graph. So I take each one of those individually, and then, yeah, all these tabs, yeah, so it's just work. Yeah, I'm just clicking through just to show you, this part's a pain in our rear, Phil's rear specifically. Because I'm the one normally copying and pasting all this stuff into there. And there's a little room for error there. So, okay. So the good things, I would say with using the Kaiser Permanente tool is it's fairly simple. It's easy. It's Excel spreadsheet. You can't truly mess it up. It gives you basic good, definitions when you're looking at this, right? It gives you, hey, interruption of services is going to be low, moderate, high. Very, very easy. Uses the basic risk probability index to give you your scores and rankings, and it kind of works. All right, I'm going to pause there for a quick second. I'm going to shift gears slightly, and I would like to ask a question. If anyone has or puts together any other additional supportive documents, I'm going to show you this document here in a second, to support their HVA's conclusions and what they're doing with the information that they have. Does anyone have like I'm gonna call it a pamphlet or an annex, a talking paper that discusses what you've put into here? Because when you kind of go through here, you're punching in numbers, and then there is a section. I think this is the older version. Yeah, this is probably the slightly older version where, but in the newer one, I believe it does ask you to put in input, how many times you've had a flood or how many times you've had this in the past. But does anyone take that information or have a talking paper, policy plan, annex that supports their HVA at all? So if somebody were to go back and say, hey, what's there? How'd you get to this ranking? How did you determine that we are less prepared for this than that? Does anybody have anything like that? Maybe, or meeting minutes? Does anybody do anything like that to support their HVA conclusion? And let's talk about from a regulatory standpoint, when Joint Commission, HVAP, whomever your accrediting body, and I'm speaking for hospitals now, when they're asking those questions, do you simply show them the printouts of your HVA and a date? What are they accepting as collaborative environment and support for your HVA? I see that, Patrick. You said you do it through committee meeting minutes. Okay, is your support or evidence? Georgia, what do they normally ask you guys?
We do it through committee meetings as well. I fill it out, but then I present it. And if anybody has any changes,
Or they're like, ice storms is way worse, should be way worse than such and such. They voice their
Uh,
concerns then.
yeah, kind of. I've never really had anybody say anything.
They're like, George has got it. I know. They're like, George has got it. Okay. Okay. Um, So, I mean, at least the group that's here is fairly familiar with the tools, obviously, whether it's SIMP. I know our health departments are very familiar with that. Again, Patrick, I know you're not too familiar with SIMP yet. If you haven't gotten a account, I would make sure you talk with Greg Atterbury, get you an account if you don't have one established, get one so you can go in there and take a look. And I'm sure Brad and Tim will be able to kind of flesh some of that out. Okay. So with that and having an understanding, I would where I'd like to kind of shift gears slightly and talk about a new tool, fairly new tool. At least this version is new. And has anyone heard of Risk or the Risk C? You may hear it as that, but the Risk Toolkit. Has anyone heard of that before? Okay. All right. Not hearing that anyone has heard of that before. Um, we're going to give a quiet, I'm going to call it it's not going to be a formal briefing on risk and a formal presentation from the folks at Asper. However, I do have Jason Campbell on from he's part of BJC. He works over at Big Barns as well as a part of our I'll just call it our corporate EM side, working up there. You guys have heard him on the calls in the past, briefing for the St. Louis Healthcare Coalition, as well as um, just some general, maybe some smock things or stuff like that. It goes with stars. He's briefed some things there. He works with Sean Eisenhower and good folks that we work with on a day-to-day basis. They have an initiative where they've started to use, or we're starting to use the risk tool as our kind of HVA linkage, so to speak. Um, Across the BJC system. So for all the HSOs in the BJC system. And I'd like to give him the floor for a moment to be able to talk about it. And I didn't know if you were going to bring up any slides. If you don't have slides, you don't have to worry about that. Or if you wanted to present from the actual tool, or I could bring it up if you'd like that. But I'm going to let Jason kind of take over to kind of discuss what the risk tool is, and then we'll go on from there. So take it over, Jason. Thank you.
Thank you, Phil. I appreciate the caveat that this is very informal because I don't have any prepared materials. We're just going to go directly from the resources produced by Asper on this new threat and hazard calculation device. So one of the, just some of the benefits that you have articulated as concerns or gaps in other tools, I think Asper was very deliberate in addressing. And the first one, as we see up there, it is targeting the entirety of the HPH sector, all of the agencies, the organizations, and the disciplines that compose our health system for the community. It is designed to be inclusive of that, accommodating their different demographics, their service structure, their standard work. It incorporates all of those variables into an objective data evidence-based product. And we'll talk more about what that entails too. But one of the benefits that's I guess one of the limitations that I have observed, experienced, and tried to account for with the Kaiser Permanente tool is a lot of subjectivity. The Hope Coalition partners here have kind of echoed that. It's a lot of going down memory lane. When's the last time it snowed and how bad was it? Everyone wants to tell their stories when we do the Kaiser Permanente workshop. And Asper was deliberate in creating a tool that tried to minimize, if not eliminate, that subjectivity and create something that incorporates publicly available data sets, evidence from historical occurrences, and thread those together into a more accurate and realistic perspective of risk. So this is a tool that, again, is designed to be data inputs from all of our partners. And it goes through 3 different modules to create a more holistic projection of risk. So the first one is what's called the THAM. It's the Threat Hazard Assessment modules. And for anything that might be an external threat, so meteorological, geological, it uses National Weather Service data to help project not only occurrences, but impacts from those weather events. It uses Department of Transportation data to determine what is your organization or agency's proximities to hazardous materials. Are you next to rail systems, river systems, highways, and interstates that might have higher likelihood of hazardous material releases that might impact your services or affect patients or care providers' ability to arrive back to your location? It uses publicly available law enforcement and counterterrorism data from local, state, and federal agencies to help create a risk profile for intentional violence that might affect your services. And then it gives a chance, very similar to the Kaiser Permanente, to provide input on what the vulnerabilities are. But where it differs from previous is it's not asking for direct quantification of a scale of 1 to 3, 1 to 4. How bad is this going to be for humans, for life and limb, for business and services, or for property and resources? It actually uses modules to kind of guide through what is your vulnerability profile for emergency management. Do you do exercises and drills? Do you evaluate functions and capabilities? And it allows that to kind of map it into the particular threats and hazards that are most pressing. It also uses formulas behind the scenes in its module itself to align vulnerabilities with the most applicable threats. So if you say, hey, we have 50% coverage with CCTV footage in our organization, that's not really going to affect your ice storm readiness, but it might create a higher vulnerability for active threat or for hostage situations or for unauthorized access or intrusions into your facilities. So it is very explicit with mapping vulnerabilities to the threats that they might be afflicted by. There's another feature too, just in the consequence, or sorry, in the criticality, and this is where it starts to lean more into the community centricity of it. So it's, I'm gonna see if I can pull up one of our old scores here. So criticality is determined just by other organizations or agencies that provide your service. Like, is there redundancy in the community, or are you the only level 1 trauma center in your community? And if you go down, the community will be hurting. So it starts to weave in the scope of service, the patient's, the patient demographics that we provide to, the at-risk patient demographics, those that maybe have comorbidities or are at a higher indice on the social vulnerability index. If community hospital and healthcare providers or EMS agencies or public health agencies are affected by threats and hazards, it starts to incorporate what is the degree of community and HPH sector impacts at large if those occur. And I do think there's value in addressing that criticality, especially when we talk about using the Asper RISC toolkit for coalition HVAs. The other part here, I mean, so this is all designed by Asper, and as we're well aware, Asper's the beneficiary, the releaser of our HPP dollars, and it uses, so this is kind of the dashboard here. It calculates your risks, identify what is your top threats, and what is going to impact your agency or your organization the most if it occurs, and it promotes actionability to align risk reduction initiatives. If we can eliminate the risk or the threat, through mitigation efforts or prevention, we build those out. If we can prepare for it by building resiliency, capacity, and actionability, we do that. But ASPR actually aligns the actions following the RISC toolkit with some of the deliverables and the requirements of the HPP work plan. So there's linkages between what you calculate as risks and threats to your agency, your coalition, your organization, and being purposeful in fulfilling HPP work plan goals and objectives that would have a direct impact in reducing those risks. And I think that is an invaluable linkage that no other tool brings to the table. So what we're displaying here is just, it's a snapshot of one hospital in the St. Louis Healthcare Coalition as they've completed the data inputs here. Everything that was determined to be an external threat, let's see if we can pull them up here. These were all calculated again by the category that they're in, and it determines what the final score is based on historical occurrence, community readiness and resilience to the effects of this hazard or threat, and what we've been able to do as lessons learned and meaningful interventions following occurrences. It allows organizations to calculate internal threats, maybe something that is unique to your agency by the services or work that you provide, maybe something that you've experienced before that's not incorporated in this universal tool. It allows you to input threats and hazards specific to what you do. One example that we've used for Barnes-Jewish Hospital is our infant abduction threats. That those are unique, those are prevalent, and those weren't incorporated in here in ways that we thought would give the most insight and actionability back to our organization. So there's a little bit of a lift in terms of getting into the RISC 2.0 toolkit. I will put all of these tools in the Teams chat so we have access to them so you can kind of review it. There's a very in-depth user guide. It goes through all the different modules, provides the standardization definitions for external and internal threats to help build consistency for how we calculate some of these threats and hazards. But yeah, it's all a web-based portal. So Phil, I saw you pull up a folder that had just a bunch of files in it. This eliminates the need for that. It's one central house for all your organizations. So Phil mentioned we're part of the BJC healthcare system. You'll see all the different organizations here that have started to access and input information into the tool. So just visualize this as, Hope Coalition as the organization, and all of a sudden you have your hospitals, your EMS agencies, your public health departments all listed out under here. So you can have unique organizational or agency threat assessments with that data potentially being aggregated for a coalition HVA output too. I know I kind of clicking through these a little bit here, but I didn't want to call attention to the user account here. So every individual user, I apologize for any background noise too. Sorry, I'm sharing from the St. Louis EOC right now, getting ready for a training, but hopefully it's not too intrusive. But everyone will have to create a unique user account and using Microsoft Authenticator or Duo or other type of cybersecurity protection app to get to it. It's pretty seamless. Just if you haven't, if your organization isn't well versed in some of these authenticator tools, it might be a little bit of a learning curve. But this how getting started guide is pretty helpful in that front. So I'm going to just kind of stop talking for a moment and see if are there any questions, comments, anything that I can help clarify regarding the RISC toolkit.
Well, I'll start here first, Jason. Thank you for the overview and in-depth kind of perspective on what it does. So team, this will be an opportunity for us to kind of ask a few questions. I'll be as transparent as possible. We're just starting to use it. We've been, as Jason kind of pointed out, as the BJC health system, we're moving towards it. But Lee or I are not, masters of using this yet. We're just dipping our toes in it. We did use the risk version 1.0. We did that was a Excel spreadsheet that was very it was cumbersome. I'm not gonna lie. It wasn't very wasn't a very good experience. This, in my limited experience of what this does, is much more user-friendly and intuitive to getting information in and pushing you into a direction so you can complete the information, which I think is a bonus. For anyone who's dealt with SIMP, it probably took you a couple years between that and egrams, state products that we have. Two things that most folks who deal with grants or have to deal with the state and providing this type of information don't like. This one has a much more pleasant user interface and how someone would interact with it. So I'll prime this with a question, and then if you guys would think of a question that you may want to ask Jason, and maybe he'll be able to answer it. But Jason, let's ask this question. You talked about community and bringing it together as a whole. Could a health department use this, or is it more specific for an organization? And if we were to call it an organization, the health department, would it be on that organization specifically, i.e. St. Clair County Health Department, not just the public health services of St. Clair County?
Yeah, so every agency type would have an opportunity to input, and if I can flip to the profile creation here, you're able to determine what type of organization you are in that health system. So if you are an EMS agency, if you are long-term care facility, if you're a critical access hospital, all of those options are available, and those actually are mapped into the overall risk assessment. In terms of how to build that out, Phil, that's something we're still trying to figure out are we able to create like we'll call it a tertiary category of building in the coalition agency types of here's all of our public health agencies and coming up with a public health HVA that could be informative to the Hope Coalition HVA. I don't know if it has that level of sophistication, and I don't want to misrepresent it if it doesn't.
No, that does help a little bit, but saying the agency type and being able to define it is key, I think, and hopefully, that helps us, be more flexible, and with the information that we are obtaining and what we can use to action, put into action, so to speak. Flexibility is the key to air power, and it's the key to doing HVAs, I'm pretty sure. So questions from folks who are on, any questions with regard to the risk tool? Don't all shout out at once, I know. All right, since I don't got no questions, that means I got to pick on folks. So I'll from what Jason did provide us as an overview, Georgia, what do it versus potentially what we're doing today, as a potential repository for HVAs going forward? What are your thoughts?
I think I would have to look through the guide a little bit. Did you say, or did he say that it was going to be for all of us together? We would all use the same and make just one HVA for the whole region, or each hospital have their own?
So I'll try to answer that, and I see Jason type. And so in part, you would have your own. You would have your independent organizational one.
Yeah, and
But
then
like, remember how I
you would
showed
make
how
one.
yeah,
Okay.
correct. And then it would all roll up to one, and then provide us a more clear picture of, the 19 hospitals and however many EMS agencies put in this information. Then that information gets aggregated upwards, and then I can look at it, and you would probably be able to look at it as well. You should be able to look at that information as well, so you could see it from a coalition perspective as well.
I mean, I think if we do this, we need to have it throughout. Everybody needs to use it and not just hit and miss.
Mm-hmm. Mm-hmm.
Yeah, Georgia, I agree with that. I think that the value is compounded the more organizations and agencies that are inputting their data, and absolutely, There's user types that can be built out, so you will not lose your individual HVA output for your agency, your organization. You will still have agency over that data, and you'll be able to update it. You will not have to recreate the entirety of the process, at whatever routineness that you completed. So you'll be able to go up there, tweak the numbers based on outcomes of risk reduction initiatives, but still be able to access that, present it to surveyors, incorporate it into your EM programs. It'll just be connected to a broader picture of threats and hazards at that coalition level. And I apologize, Phil. I have to step out. Our training starts at 11 here. This has been a wonderful conversation. I appreciate everyone's inputs and thoughts and perspectives on different HVA tools. If there's any questions, any comments, concerns, or clarifications that continue as the workshop progresses, please do not hesitate to reach out, and I'll be happy to address them offline.
Awesome. Well, thanks and enjoy the training. I appreciate it, Jason.
Of course. Thank you. Take care.
All right. Other folks' thoughts. I'll echo George's statement and Jason's with, if there's something we want to go down, yeah, I think, I would put this as a part of, inside of our EOP in our preparedness section where we talk HVA, that, coalition members will update, maintain their HVA information in the ASPR Risk 2.0 toolkit, blah, 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 some language to support it. But I do think that, yeah, if it's something we want to start, that we all go down it kind of hand in hand. From a public health perspective, do you guys, I know you're doing it in SIMP now, but like I showed you our scope of work, is it a requirement to do it in SIMP, or is it, is it required to do in SIMP, or are we just doing it that way because that's a tool that we have available to us and the state's still paying for it? Anyone from the health department can answer that one.
That's just the tool that we've got available to us. I'd be willing to use another tool, but so we would be willing to play along here. But that's what we're using right now. And, we hear the rumors that we're not going to be using SIMP. So
Yeah.
we'd definitely be willing to explore other options.
Okay. Anyone else from the health department's thoughts? Thank you for that, Kara. Is Kendra still on? Kendra, you got any perspectives on it? Let's see. I'm looking.
I would say I'm agreeable with Kara. I mean, we're used to SIMP, but it's not that we would not be voluntary to try something new.
Okay, that's good to hear. Molly, any thoughts from you guys? I don't know if you got mic access. Debbie, anyone else? Greg, any thoughts? Any perspectives on the future? I see Molly. Okay, there you go, Molly. Not a fan of SIMP the way it is. Okay, it's organized, just difficult. I understand. I commiserate with you sometimes. Greg, what are your thoughts? I mean, any outlook right now on SIMP? I know we do have access through this next year. Has there been any other discussions?
My thought is, and no official, that everybody who were fans of SIMP are no longer with the department, I would say. So while I can't give you any definitive answers, the support for SIMP is greatly diminished in the department. So it would not surprise me that in a year or so or two that it might be replaced by something else. And I think that's what everybody out in the health departments and everything else is kind of hearing the same thing. There is a love lost for it. So we are no longer, in the sense that, we did a lot of stuff from a regional standpoint, are not doing it in SEMP anymore, because we don't know what's moving forward. So as an example, all of the EMS stuff was being done in SEMP, the SOGs. They were planning to do the future system plan in there, and all of that, for the most part, with the exception of a couple of people in the state who really know how to do it, are no longer doing that. So I think it leads one to believe that its days are numbered. And that was a committal, non-committal statement.
No, I totally get it. I appreciate it. Just want a little, a perspective, so to see how, how we really kind of can go forward with it. Go forward with whatever we're going to do. I do know that with anything, there's a learning curve. And I mean, Lee, what are your thoughts on what it would take to make sure that if we were to choose to say, hey, we're going to use the risk toolkit as our primary means of HVAs for the coalition, what would you think is a good training timeline? Again, we're not experts with it yet, but what are your thoughts on a training timeline?
I mean, it's not going to be quick. It is still relatively complex. I mean, if we do the build out like we discussed yesterday in the office, and it might be a little smoother, but I mean, it's still going to be an initial lift. If we started on it between you and me, we could probably get everything we need to do done by the end of the year.
Got it. I know that from a work plan perspective and the deliverables standpoint, um, we have until the 31st for the HVA, 31st of January. So, definitely wouldn't be, I think, we'd have to stick with what we're doing, from, we'll still have to use the Kaiser Permanente tool that we're using today, because that's what we had settled on for the past couple years, unless somebody wants to go back to SEMP to finish this year. But having their updated versions of that submitted so we can just meet the deliverable and then move forward. I honestly think, just looking at it, that it would probably be like at least a 6-month kind of timeline if we were to say yes to this, and hosting trainings and mini workshops and how to fill out the information once we've gone through it. Again, what I do know is that once the information's in there, now you're just tweaking the information over time. So I don't know if, Lee, if you talked with TJ on what the initial timeline was when he put in the information. I think they may have imported their risk 1.0 information and just have to update, if I'm not mistaken. So I don't know what a fresh install would be, when everything is blank and you got to make all those choices.
Yeah, that I'm not sure. That's definitely a conversation I can have with TJ. And folks, just to clarity, the build out of this, like we were just saying, I mean, it is a little bit of back end work that's got to be done. But once it's done, it works great as far as longitudinal tracking. You consolidate all that information every year, easily tweak, update, and it gives you running totals, which we currently don't have.
Yeah. Okay. I'll pause for a second. Anybody questions, thoughts on the whole HVA processes that we go through, and how we can better kind of talk to our vulnerabilities as a coalition, and where we need to, how we can inform ourselves more to make better strategic moves? All right, hearing none, I'm going to share our supportive documents here. I think I've shared this maybe once in the past. This is we're updating this now, but this is our HVA for the hospital. It's like, how many pages is it? What is it, 40 something, 42 pages from front to back. But what it is, this is kind of a bridge between a THIRA, community, a kind of full assessment, um, and an organizational HVA. This is what we use. That's why the question that I asked earlier regarding what do you use to support, and most of you guys said minutes, and I think that's probably standard. And here's the document. We kind of extrapolated that into one of our support NP and put it into kind of a talking paper annex format. So we kind of show the basic ranks. We got all the other supporting documentation behind this. Um, Folks who we get information from. We define our community and service area. And this can, well, I'll get to it in a second. We define our kind of community and service area. We talk about the climate through here, topography, air quality issues that we have that affect healthcare, um, asthma, COPD stuff. And again, this is just we using our St. Clair County information to fill that out. We talk about what noteworthy hazardous events have occurred in the community. For natural events, we break them apart. Flooding, storms, take some of the St. Clair County storm data. And as you can kind of see, man, our winter storm that we've had over a significant amount of time, yada, yada, we rank all those. We take a look at our workplace violence within organization. We do that. What else are we doing here? And then we identify, um, you know, some of the other threats. Talk about active shooter incidents, what's occurred recently. Like we'll probably be adding the incident that we had in St. Louis not too long ago. I forgot which hospital it was in. I don't know if it was Christian or whichever hospital that was. All of our technological events, aka power failures, we kind of detail those. So this is all our supporting information for that. Then we get into our community risk portions. This piece right here was an ad that we put in here um, because there is a spot in the federal registrar for the CMS guidelines that for your conditions of participation, that you have to kind of show, that you're doing it as a community approach, yada, 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 for your planning. So we included some of this information here. We have some of this information inside of our regional EOP as well. So our electrically dependent population, we put our social vulnerability index information in here. And again, this is a kind of a carbon copy of what we have in the regional plan, and this is something that we had in our primary EOP, and we extracted to put into this specific annex. Our pediatric considerations that we have in and around the community, our geriatric considerations that we have across the entire region that we show where we have regional nursing homes, and then our inpatient and outpatient at-risk populations. So we identify our children, senior citizens, what risk mitigation measures we are implementing or we have implemented across the campuses to help those for that specific group. Same with folks with chronic medical disorder, excuse me. We give a risk analysis. We talk about our neuroscience PT building out here, wound care clinic, et cetera. Then our risk mitigation measures for each one of these. So language diversity. What else we got in here? Individuals with special needs, folks with lack of transportation, and pharmacological dependencies. And we risk each one of those out. And then this is just supportive information, our calculations. And this was a DQE one. This one wasn't the Kaiser Permanente, but we'll probably replace that this year. And then there's some other supportive documents. So this is what we use. More than willing to share with any of the organizations that are on here, should they want to expand upon their HVA documentation. So let me or Lee know if you would like a copy of that. So that leads me to my second point of, we talked in the past about potentially expanding our region's version of this exact same thing a regional version of this annex to our EOP, to not only provide support and documentation in the coalition assessment tool, as I kind of outlined earlier, so the state and the feds can see, hey, this is what they did for their, this is how they're supporting their HVA, and this is all the information, blah, blah, blah. And it's in the risk toolkit, but this is the kind of talking version of what's in risk. Just not sure how we could, do it over such a large space, how we would do that. But I'm open to the thought that maybe it's a possibility. And I just don't know. I'm not sure if it's something that we need or not. So I wanted to kind of get a pulse check from you guys. Do you think this would be just overkill trying to create an additional document? And that a tool like the RISC, or if we stay with the Kaiser Permanente tool, is enough. I'll tell you from a regulatory standpoint, it is enough. The using the RISC tool, us having a workshop such as this, or going over some of our vulnerabilities as a group, once we've completed a RISC tool or the Kaiser Permanente tool. But I'm trying to look at something that, if we're doing the work for some things and it can be beneficial for other folks, do we need a talk annex or supportive document that shows our work, what we put in there together, and how we see ourselves from a regional perspective with regard to the HVA? So I'll shut up there and open it up for any dialogue. Is it something we need or not? What do you think? Hearing nothing, that means I gotta point out somebody. So I'll start with Greg. Hey, Greg, so do you think we need something like this? Do you think there's any benefit to us from a region, or is it just more words that maybe folks aren't going to read?
Um, that's always a concern. Always a concern when a new document comes out, especially in how lengthy it may be. That people are not going to pay any attention to it. I don't really, since I am not at the level of the hospitals or health department, I don't really feel like I can weigh in too much on that. Of course, the state goes through all of this, and I have that access to me. I would really see what the hospitals and health departments think. But you are absolutely right when you say that sometimes switching to another document can cause it not to be as readily embraced by the masses. But that's my input.
Indeed. No, thanks for that. No, I appreciate it. Anyone else who hasn't been picked on yet? Let's see. Thoughts, man, from a hospital perspective. Do we need additional supportive documentation for a regional HVA? See, Pat's still on. Maybe we lost him or he had to step out. Georgia, thoughts from a hospital perspective?
I'm open to getting a new form. Somebody else said that SIMP was a pain, and I agree.
Oh, well, thank you for that. I'm talking about more specifically the document side of, like the documentation side. Do you think from a regional perspective, not from the hospital, I wouldn't want to press upon you that you would have to develop anything like I just showed you that we did for our HVA, but from a regional standpoint, do we need a talking paper? And I'm saying talking paper, but whether it's an annex or some form of documentation that shows this is what we sussed out when we did our HVA. When we look back, when we take the 50,000 foot, 25,000 foot, and 5,000 foot look at all the ones and zeros that constitute the ranking of our HVA, that says lightning is the #1 threat to the Edwardsville region. I'm just making something up. Do we need to have the supportive documentation behind that? We will have, as obviously you were on when we had our strategic planning meeting a couple of weeks back, a lot of that information could reside there, but it won't speak to every vulnerability and everything like that. It won't be a full talking paper about all of the, flooding occurs in this area more often, and RIA healthcare facilities, could overflow into XYZ hospitals, so you should be aware of that.
Well, I think
Like a
something
doc.
like that, I'm sorry,
Mhm,
I misunderstood your question earlier, but
mhm.
I think something like that would be helpful
Okay.
to everybody in the region. I know it's probably a lot of work on whoever's gonna do it, but
Yeah,
it's a big difference between me down here
exactly.
and up at the top of the region.
Or going out as far east as Fayette. What Tina has
Yeah,
to deal with day to day is different than what you're gonna have to deal with. You got a flooding river and prisoners to deal
yes.
with to deal with. Um, from my health departments, I'm sorry, I'm sorry, I saw Patrick did put something in. Let me check the chat. I'm sorry. I do see Molly and Patrick. He said, I'm sorry, I had to step out for a minute. I heard that, Patrick. I may return back to you. And what Molly says would be great if it all filtered together on future programs. I think this is a recommendation at the state level. I don't mind sending in a form, but they don't seem to change significantly per year, per each year. I guess sending it in every 3 years or something would be a big deal. Okay, wouldn't be a big deal. I see what you're saying. Okay, so you're saying more so the updating and the care and feeding of the information. And I am. That's me as well. I will, if I were to develop something, or we were to develop something, not just Phil, but we put together a document, it would be much more of a strategic document. It could not be a annual or biannual HVA. I've asked the question at the state a couple times. I'll ask it again this year. CMS says you have to do your HVA every other year. Why would we have to do a regional HVA annually? When the organizations below us do it every 2 years. So, okay, so thank you for that. And again, I agree. I would make it more akin to a thyroid, something we did every three. I'd really recommend probably every 5 years that supports it, and then that would support our strategic plan even more. So we can have that because the strategic plan will have again, the 50,000 foot view of it all. So it will mention some of those vulnerabilities, whereas that actual um, health system thyroid for our region or health system HVA for our region would have the 5,000 foot view where you got more details there. Okay. All right. I'm gonna pause here. We've been going for about a little over an hour. We started, I mean, we actually started at 10, but we didn't really get started till about 10:15. So thoughts. I'm gonna open the floor. I'll pause it here for a second. Does anyone need assistance with any of their HVA work that they're doing, or they think they got it kind of pretty square? Okay, nobody needing any help. Okay, I do think it'd be prudent that we stay because next week we will talk at the coalition meeting. So my plan is to um, say that we looked at these things. I will make a pitch for the Risk C toolkit because I think it makes sense. That's where I'm at right now, at least. That's a way that we could go forward with, which means that we'll probably have to do a more formal briefing, which we can do with the folks probably at Asper, or by that point in time, maybe we've got it built out a little more at BJC. But during that time, again, of making a pitch, my point will be to that we'll continue with the Kaiser Permanente tool. We'll have basically submit it by no later than this date. That way we can consolidate the information. So being in November, so November, December, give everybody 60 days, and it gives us 30 days to meet the work plan requirement of January 31st being complete no later than, and then provide some briefings and educational opportunities on what the risk toolkit is. Unfortunately, there aren't any YouTube videos out there right now on ASPR's website or anywhere else for that matter. And then maybe make a vote going forward. So for starting BP1 of next grant cycle, we may be using a different tool going forward. But again, I will pitch and push to go forward with the Kaiser Permanente tool. We'll consolidate all the information per usual, and then move forward after that. Anybody think that's a stupid idea, or think there's maybe a better way we can approach it? That's
I
5
think it's a good
Mississippis.
idea.
Oh, good. 5 Mississippis, and Georgia says it's a good idea. Book it. That's what I'm gonna say. Where's the judge's hammer? All right. Okay. All right. Well, this has been great. I appreciate everybody's perspectives here. It helps. I do think, when we do have these conversations, it makes us better, gives us more opportunity, things from different vantage points, so we can make sure that we're doing the right thing in the end. I don't want things to just feel like, hey, Phil said we got to do it like this, da, da, da. I don't want to do it. I want us to at least, uh, I try to build consensus as best I can, but I do think we always should be striving to do something better than what we have been doing. If not, we just, this is what we always did. And sometimes I feel like we could always fall into that box, and I want us to keep striving for greatness and better ways to do things. Make your lives better, and then make the folks who we serve out here in our communities better. Patients, coworkers, and otherwise. So, okay. With that, I'll pause for a second. Anybody got any last parting shots? If not, 5 Mississippi. I will end the conversation here. We'll draft up some notes and shoot them out to the coalition so folks can know what we did today. This will be uploaded sometime this afternoon to the YouTube page. If you wanted to go back and say, what was that guy Jason talking about, and where did he show it at? And you've got those links in the chat. So if you need to go to any of those links, they're there now. You can kind of revisit them at your leisure. All right. Well, we're going to end it here, and great talking to you guys, and I will talk to most of you guys next Wednesday on the coalition meeting. Take care. Ciao.
Thanks, Phil.